Over to you, Dr. SHREYAS.
Thank you so much, sir. At the outset, I'd really like to thank you for having me as a part of your course. It's truly an honor. It is almost impossible nowadays with the recent advances in biometry, the number of array of equipments across different companies now available to cover all the devices. But I will try my best to highlight some of the salient aspects of what we need to look into and try to cover as much as possible. Frankly, no talk in biometry, although we are all focusing a lot on optical biometry, the advanced tomographers which are combining. Ultrasound biometry very much still has a place in today's practice, and even, I mean, if somebody is starting out, optical biometry is a little out of reach because of the costs. I don't think there is absolutely any problem as long as a good immersion ultrasound is done. You still can get target emmetropia in a vast majority of your patients, except in a select few situations. And I really genuinely think that just because you don't have an optical biometer, there is no need for anyone to stay away from premium IOLs. At our own center, we have 15 centers, out of which there are 4 centers which don't have access to an optical biometry, but still they do all the torics and multifocal IOLs, and we've analyzed the results, and we find for the vast majority of cases they are still able to hit emmetropia, and by adapting the newer formulae which are available, which is very, very good. Contact definitely has no role to play, and definitely we should start only by using a good immersion biometry. Look into very few salient scans, like ensuring that you get the appropriate spikes. If you don't have the spikes in place, please repeat the scan. Have a skilled optometrist technician do it, and ensure the same person is doing it each and every time. So once you have a trained biometrist, your immersion scans will give results which are just as good as optical biometry. Adjusting the gain, playing around with your machine for compromising on sensitivity to resolution, depending on the if you have facing a denser cataract, increase the gain. If let's say you're in a practice where retina surgeries are also done and you have a silicone oil filled eye, reduce the gain. By playing around with these minor adjustments in the this thing, you can really ensure you get good results even with your ultrasound immersion techniques. One challenge is, of course, that the fixation is definitely there in optical, which gives you more accurate measurements, but especially in high myopic situations where the visual axis and anatomical axis can be quite different, especially if the patient has a posterior staphyloma. So these are situations where the ultrasound biometry is going to give us a little more erroneous value. And optical biometry, definitely, the rest of the talk is going to be on that. And there's a lot which has come in, a lot of advancements, foveal imaging which has been incorporated into our optical biometry, which really ensures not just patient fixation subjectively, but objectively we can also look at the various parameters. To start off with, comparing IOL Master 500, the older version of the IOL Master, with the Lenstar 900, they were excellent agreement between the devices in terms of keratometry, ACD, axial length, and white to white. But in terms of corneal thickness and lens thickness, the IOL Master 500 was found a little wanting, which has definitely now been corrected with the 700. So we look into the aspects individually. First about keratometry. Again, if you're using an ultrasound biomicroscopy, a good manual keratometry still holds good, and you can still get excellent accurate values on manual keratometry also. Using the optical devices, really it matters very little which optical device you're using. Though I have listed Lenstar 900, 500, 700 based on the papers which I have quoted, but even if you're using a Tommy or a Nidec or any of the other equipment which are available, all of them have excellent inter-observer agreement and different measurements which are repeatable. Tomography is useful, definitely in post-LASIK cases, and also to rule out patients with certain irregularity in their corneas. Toric IOLs, we must understand, are useful more for orthogonal, not for the irregular astigmatism. So for you to not have any surprises, if you have access to a tomography, it's definitely useful. The IOLMaster uses fewer points. LensStar 900 definitely analyzes more points within the 3 millimeter radius, and therefore has certain advantages of its own. But the IOLMaster, although has fewer points, this telecentric keratometry makes it useful. So what basically it means is that even if we are slightly out of focus, the distance between the dots do not change. Because the distance between the dot do not change, the observer who's doing the investigation need not be pinpoint accurate. If you have a slightly uncooperative patient is not keeping the head perfectly steady, even if your dots are a little out of focus, you'll still continue to get excellent and repeatable recordings. So that's one of the advantages of telecentric keratometry. But what has really been a game changer in the recent years is our ability to image the posterior cornea. Now, we've been talking about posterior corneal astigmatism for the last few years now, and the importance of it in toric IOL selection. And really what the IOLMaster 700 does is, it has corresponding points of measurements which are projected onto the posterior cornea as what we are measuring on the anterior cornea, giving you a posterior torus fit. And this is now calibrated. Now, the IOL power calculation gives you the keratometry, it gives you the anterior, the total of anterior and posterior, and then you have the posterior values also separately, which is really adding a lot of values. And the biggest advantage of TK is, or the total keratometry, is that it has formulae which are made for TK. Because previously, while we had Pentacam and Galilei and all which were giving us posterior corneal astigmatism, you were not, when we input values of the posterior cornea into the toric IOL calculators versus using the mathematically assumed values, the actual toric input data of the posterior cornea from Pentacam or Galilei was performing worse than the mathematically derived value. This was because the regression formulae were not suited or were not adapted to the way the values were being measured by the tomographers. But with the IOLMaster 700, you have the newer formulae like the Barrett TK and the Higgis TK, which are made for this TK values, and they are definitely improving outcomes. While it is definitely very difficult to reach statistically significant outcomes when already our measurements are so near emmetropia, but we are seeing a significant improvement and growth in the in the statistics, and the overall number of patients with less than 0.5 diopter astigmatism post toric IOLs is significantly improving. Even in post LASIK eyes, which is a genuine challenge, we are seeing that the Barrett True K TK is performing better than the Barrett True K or the ASCRS average or Shamas and Higgis L, which is what we were predominantly using before. So now really you have a one-stop formula which is available, and the Barrett True K TK is really performing extremely well. Along with that, and it is just to show that the value of the TK is what is more important than the formula itself. It's not just the Barrett True K TK which is working well, but even the Higgis TK which is performing extremely well. So even with other formulae are available. Of course, you have excellent measurements of angle alpha and angle kappa. I'll not get into the details. There's a slight difference between the measurement in this compared to the values which you get on certain other equipments like iTrace, but definitely you do get very, very good values. Quickly moving on to anterior chamber depth measurements, which are again very, very important in predicting your effective lens position and other lens thickness and other things which need to be measured. IOLMaster 500 was measuring from the epithelium, which was, and also was not very good in pseudophakic eyes. It was mostly useful in phakic eyes, but that has been changed in the IOLMaster 700. LensStar, ObsCan, Pentacam are all very good for ACD measurements. When it comes to axial length, now this is where these true B-scan biometries have been a game changer. By using the swept source OCT, you get a real true cut section of the eye, cross section of the eye. You can measure the corneal thickness, lens thickness, and image the fovea, image the fixation. Now this is where it has become very, very important. You can see an example where you have good fixation, you have repeatable measurements, you're able to image the fovea, and the patient has very similar repeatable IOL power calculation. Whereas in patients where the fixation is not good and the foveal pit has not been imaged, it's a very, very small difference in the axial length, 190 microns, but that makes more than a diopter of difference when it comes to the IOL power calculation. So it's really important we ensure this, and the foveal pit is accurately imaged. You can also, it alters your workflow. If you detect any basic macular pathologies, that can also be detected. Can I take a minute longer, sir? So the last aspect of the talk which I'd like to talk about is combining biometry with topography, which now a lot of devices are able to do. You have traditional biometry devices like the LensStar, IOLMaster 700, Aladdin, which are essentially biometers but are now combining a Placido image with the biometer. Or you have topographers like the Galilei G6 or the Pentacam, which were originally tomographers but are now giving a component of axial length. Now, suffice to say that they are giving repeatable and comparable results. While the Placido images with the biometers are okay for astigmatism, they are not really useful as far as keratoconus or other imaging is concerned. It is more for your toric IOL and other calculations, but the accuracy, the results are comparable between both the devices. Just a quick example of an image on the TopCon, which is giving you a lot of data from the Placido disc. You get keratoconus screening, you get the Zernike values, you get pupillary data. Also, in one single shot, you are actually able to analyze all the parameters of the patient. This is from the LensStar, and with the TK, because the TK values are visible, the toric IOL selection is visible, the whole method of counseling, talking to patients, everything becomes a lot more easy. Although, like I said, these images are definitely not transformable to what you get in the tomographers, but are accurate enough for the K values which we require. So to conclude, we have excellent imaging systems nowadays, and with the 5th generation IOL formulae, Emetropia for everyone, as Sir said at the beginning of the session, is a real possibility nowadays. Thank you so much for your kind attention.
Thank you, Dr. SHREYAS, and I think he has to go to another course, so if there are any questions regarding biometry, you can just, go ahead.
Optical, that's what I wanted to say this, and I could have put innumerable other papers which compare one device with the other device. Optical biometers are definitely the way to go. There is a certain accuracy which does improve. Whichever optical biometer you're able to get hold of among the standard companies which we've discussed and I put up in the slide, they are all having excellent agreement, excellent repeatability, and you will do well to purchase any one of them. I have no financial interest in any one of them, but definitely you can buy any one of those equipment.
You'll also have to look at your other equipment. Suppose you have a Zeiss microscope like the RTO800 or the Lumira 700 with the Callisto system, then it makes sense to go in for a Zeiss IOLMaster 500 or 700 because they are linked and your workflow is much easier. So these are all things that you need to take into consideration. Of course, like SHREYAS said, telecentric keratometry makes it much easier. If your optometrist doing it, an inexperienced person doing biometry, it's a little more forgiving. And you also have the foveal pit, which you can see whether you're on the visual axis while measuring the axial length. So these are all small things which kind of matter, but you'll have to look at the features and the price and the other equipment that you are having and finally take a decision. You also have other equipment like the Pentacam Wave AXL, Pentacam, which also gives you the axial length and other measurements. You have the Anterior. There are quite a few devices which are there now, but you'll have to kind of look at what suits your practice and what are your needs, what kind of work you're doing, how much of premium IOLs are you implanting, and then decide on it.
And wonderful equipment like Anterior, other even MS39, OCT based tomographers, that's really a talk in itself, which is really improving the accuracy and the detailing which we are able to get of individual components of the cornea, anterior segment and lens. It's definitely a game changer.
Thank you, SHREYAS.